so very pleased to have with us today Peter Hendricks, and you see his title. You may know that he's at the University of Alabama, Birmingham. He's actually the Heersink Endowed Chair. He also, in the past, I guess, 14 months, was made the director of the Psychedelic Research Program there, which is very suitable considering how many years you've actually been doing this work.
Yeah.
You were doing work with psychedelics before it was in its Renaissance phase, so-called, before it was fashionable. You are really part of the OG, I think. So we're very, very grateful to have you with us today. And of course, you're on everybody's radar because of the JAMA article that came out last month. And basically, the very, very careful data collection that had to go into it to get the article of all articles, psilocybin and cocaine use.
Yeah.
So we're really pleased to talk with you today. And thank you so much for carving out time in what I know is a crazy schedule. And I knew it would get crazier as the summer went on. So I'm grateful we could get this in on June 1st. So Peter, please go ahead.
Well, thank you for all those very kind words. And I'll tell you, I'll present some of the data here. Please feel free to interrupt with any questions. I mean, it's always kind of awkward just speaking into a screen without really getting to see most facial expressions.
We can gesticulate wildly if you want to.
That works for me. Yeah, like just feel free to opine. I'll tell you this about the cocaine use disorder study. A number of people have asked why it took so long, and there are a number of reasons for that. And one was that we had a very modest budget, and we were doing this work before we really understood what the political landscape might be like. As you can probably tell from the way I speak, I'm not from Alabama. I'm from the Washington, D.C. area. I'm from Fairfax County, which is sort of a notoriously blue part of the country. And I moved to Alabama from San Francisco. And, one concern was whether the project would be received by the political powers that be. As it turns out, it actually worked beautifully to do this work in a redder part of the U.S. with less regulation. But we were very deliberate about how we did the work, and we were careful not to shout from the mountaintops that we were now beginning this line of work. So we were sort of stealth in the way we recruited people at first. And by the time we had some comfort with our recruitment and retention strategy, and we refined that with time, and by the time we felt very comfortable administering the drug, COVID came into the world and threw us for a loop. But I also want to mention that it add to that maybe a year of preparing the manuscript, submitting the manuscript, waiting for reviews, receiving on average maybe 6 reviews, where 5 were very positive, but the last reviewer would say, but I'm really concerned about unblinding and don't think I can believe everything I see or anything I see.
Woo.
And I think that's an important point to point out, because that's where we are right now in the field, that unblinding is looming large. And as you all know, in the addiction space, these are populations that have long been marginalized and that face a lot of stigma. So I think that the two things that worked against me were usually from a 6th reviewer who may not have been a substance use disorder expert, something like, well, we know that these are populations that are notoriously untruthful. You can't take what they say at face value.
My God.
Wow.
You didn't collect urine samples every single day. And there was an issue with unblinding. So I just don't believe the data you reported. The effect sizes are unusually large. So reject. And this happened at maybe 5 journals. And I did aim very high, but I'll tell you, like each time, I don't want to call anyone out, but each time it started with a member of an editorial board who saw my presentation and asked me to submit the paper, or had heard about the paper and asked me to submit it for review. And so I did so at the editor's invitation. So you can imagine the frustration of being invited to submit to a top tier journal, wait a month or 2 before getting reviews, 5 of which are very positive, but the last reviewer says, unblinding though, and you're kind of back to the drawing board.
Wow.
So that was about a year just to get the paper published. And I mean, the good news is I think I've heard every single critique that I could hear. Feel free to repeat, but I've probably heard it all at this point. And maybe the challenge for you will be whether you can bring up anything I haven't yet heard. So let me first mention, I'm here talking to a group that knows addiction well, so much of this I could probably skip over, but I do think it's interesting that in very recent years, cocaine use reached a global high. That we're in the US and abroad, the use of cocaine is apparently at all-time levels. There's more cocaine being produced and distributed and used than ever. And there was also a record high of cocaine-related fatalities, mostly related to fentanyl ending up in the drug supply. But it remains a major public health issue across the globe, and there are no FDA-approved medications for cocaine use disorder, though dozens of medications have been tried. And it's just a very difficult nut to crack, as you might imagine. Now, why did we decide to work with cocaine use disorder? I'll tell you, I'm a psychologist, so I don't really know a whole lot about drug development, or I didn't at least 10 years ago. And my first interest was evaluating psilocybin as a method for preventing recidivism in the criminal justice system, because much of what I do involves interventions among people in the criminal legal system. And one of my physician colleagues had to point out to me very gently that that's a really neat idea, but being in the criminal legal system would not be an indication. There needs to be a diagnosis, obviously. That's how that works. But, as psychologists, we would develop interventions to prevent recidivism, and you wouldn't necessarily need a diagnosis in this case, but I understand it now. So we switched gears a bit, and we decided to approach cocaine use disorder in large part because in our local community corrections criminal justice diversion program, cocaine use is the strongest predictor by far of recidivism and involvement in the criminal legal system, and is, again, many of you probably know major stimulants are implicated in risky sexual behavior and STI transmission, and as it turns out, there was and still is no medication that's really proved useful. Contingency management, I think, works, but there are some barriers to its implementation. There could be similar barriers to the implementation of psychedelics, but there may be in the audience a contingency management expert. I don't mean to besmirch this. I think it's great that it exists, but it has some challenges, and I think we need more than just contingency management. So what do? We conducted a quadruple blind randomized control trial, which I realize sounds especially fancy, but we just mean to say that the participants, the assessors, the therapists, everyone, including the statisticians, were blind to condition or group. We tried our very best to account for some of the issues here around unblinding. As I said, we started data collection in a very intentional way. We didn't want to move quickly. We were learning really as we went along, including how to best recruit and retain the population, how to explain the effects of these drugs to a population that may not have had much exposure with them, as you'll soon see. Most of our folks were very low income and just haven't been exposed to the media coverage, which I think is rather uncritically positive for the most part. So they haven't heard of Michael Pollan. They haven't seen Netflix specials. And in most cases, the response was, I don't really understand this. You're going to help me stop getting high by getting me high? And it can be difficult to explain that, especially when the folks in question haven't had experiences with psychedelics. And if anything, there's a language around psychedelics, at least implicitly, that suggests they're bad. For instance, like if Parker's tripping, it means he's not thinking clearly. He's behaving erratically. So we tried our best to work on how we can explain the effects of these drugs, explain the rationale in a very transparent and intentional way. And with community partners, this wasn't a CBPR, but we do have tight connections with our community partners and try to engage with them as equal partners. Okay, so we administered a rather large dose of psilocybin. The median dose in the study was 32 milligrams. And our comparator was diphenhydramine. I wanted to administer more than 100 milligrams. My IRB wouldn't let me. If I'd had my way, it would have been 250 milligrams of diphenhydramine. But we chose diphenhydramine at least in part because there's some similarities in pharmacodynamics or pharmacokinetics. We provided a lot of psychotherapy. That's important to note here. And the reason for this is, well, again, this was uncharted territory. We felt, as a matter of safety, prioritizing safety, and even doing this in the most ethical way possible, it was better that we provide much more psychotherapy than may have been needed than less. And I think one thing we learned from this is that we could probably provide less. In part, that's one bit of feedback that participants provided to us. But we would have provided up to 5 preparation sessions, mostly focused on establishing therapeutic alliance and administering a manualized cognitive behavioral therapy that was developed in the 90s by Peter Monti's group at Brown. And there was some psychoeducation around the unique subjective effects of psychedelics and how to best mitigate some of the more challenging effects. The so-called integration sessions were primarily focused on, I think, natural problem solving and continued CBT. I don't know if anyone here has a background in motivational interviewing. I didn't really think of this as a motivational interviewing study, but I do have some clinical observations that would suggest there is overlap, and I think Michael Bogenschutz would probably agree. But if people had insights after this experience and realized, I need to make this sort of change, then we would engage with them using what I would call natural problem solving. So Parker, I'm just going to keep pointing you out because I know you. If Parker said, I realized I really need to stop spending time with Christopher because all he ever does is smoke crack, I'd say, all right, let's come up with some strategies where you could communicate assertively to Christopher that it's time for that friendship to end, and come up with some other things that you could be doing instead of spending time with Christopher. What are some other things that you could be doing to fill your need to affiliate, socialize, and do things with your time that don't involve cocaine use? Now, this was a pilot trial, so we had 3 primary outcomes. We registered, pre-registered all 3. I'm sure they correlate with one another, but from my perspective, they are unique in different ways. So one is a continuous outcome, percentage of cocaine abstinent days. We collected urine drug screens wherever we could, and we would have verified their report with their urine toxicology. We'd like to see abstinence increase the time. We also wanted to track complete cocaine abstinence, so how many people who claimed after drug administration that they hadn't used at all. And then I was interested in time to lapse, and we used a survival analysis to track that. My graduate mentor was especially interested in relapse prevention, and I was inspired, like many people, I'm sure, Anna, you were, by Alan Marlatt and relapse prevention theory. So I was interested in this as an outcome as well. So I think one thing that's important to mention is, though to date, the studies of psychedelic interventions have recruited unusually high SES samples, we had what I think was a representative but underrepresented population in the literature, which is really a shame. So we did have people who I believe are representative of the population of cocaine users here in the Deep South. They were primarily men, but also primarily African American. And 65% of the sample reported an annual individual income of $20,000 or less. And you can see a bit more. There were some people who didn't have stable housing, and educational attainment was on the lower side. But again, consistent with the population here in Birmingham. I think this is really important because I hate to always give him a hard time because he's a friend and colleague, but Michael Bogenschutz in his trial of alcohol use disorder, the median income in that sample was $100,000 per year.
Wow.
And I think for those of us who are already very weird, if you're familiar with that publication, Western, educated, industrialized, rich, and demographic, for those of us who live in our bubbles of overly successful people, then $100,000 per year doesn't sound like much, but that's well above the U.S. median, which I think per household is around 40 or 50,000 per year. So the big question,
were they primarily smoking cocaine?
Oh, that's a great question. We reported that in the paper. You could look, I think, in table 1, it would say a bit more, but yes, they were primarily smoking. There were some who snorted. It may have been, once I publish papers, sometimes I just forget the data altogether. But it might have been like 75% were smoking and a quarter were snorting, but that was equally distributed across the 2 conditions.
Okay. And I was just curious too, sorry, on the other slide. So when you were talking about diphenhydramine, looking back now, I don't think, has anybody else used that as a comparator? Because it seems like it was a bit of an odd choice when we saw it, but it seems like it worked really well. So looking back, do you feel like that was a good choice, and would you have done anything different?
Yeah.
Yeah.
Yeah, so at the time that we designed the study, there were a handful of us, all associated with the Hefter Research Institute. So everybody who was interested in psychedelics could be in one room at the same time. And at the time, it was Roland Griffiths and Dave Nichols, Steve Ross, and Michael Bogenschutz, Franz Wollenweider from Zurich, since retired. Bill Linton, George Goldsmith from Compass were there. I'm not saying this to name drop, but just to tell you, like, this was our meeting of the minds. And at the time that we designed the study, the prevailing thought was that perhaps diphenhydramine would be our best comparator for a few reasons. Some are practical. It's over the counter. It's safe. It's inexpensive. You can buy, huge supply for a dime. But our thought at the time, at least, was that the people would know that they've received an active drug of some sort, and the time course would be largely similar. Michael Bogenschutz in his JAMA Psychiatry paper did use diphenhydramine as a comparator. Otherwise, USONA used niacin. Compass used low-dose psilocybin. And I think the field is mostly moving toward lower doses so that you can accurately say to participants, you are getting psilocybin.
Yep. Right. Yeah.
If I could go back in time, I think I would, if my IRB would let me, I would simply tell participants, you are getting psilocybin. And the dose range would be anywhere from 5 milligrams to 40 milligrams. One thing we did communicate with them, and that I would continue to communicate, is please note that the correlation between the dose you receive and your subjective response, your experience, is imperfect, which means sometimes people receive even open label placebos and report on self-report forms mystical type experiences. And sometimes people receive very large doses and have very little to say. That's a fact. Also, we do not assume that one must have a very memorable subjective experience to benefit, to receive some sort of therapeutic benefit. The important point being, it's okay if you don't experience much. You may have still received the active medication, and you may still benefit from this despite not having one of Roland Griffiths' complete mystical experiences. As to what I think so that would be my approach now. In a study of fibromyalgia, we're using dextromethorphan as a comparator. And we're using it in part because there has been some research on dextromethorphan for fibromyalgia, and we generally know that it does not appear to benefit the pain symptoms beyond the acute period of drug action. And we'll see how that performs.
And Peter, I promise not to interrupt you too much, but
yeah.
I was interested in the fact that you were doing an mg per kg kind of dosing rather than just a straight up dose. What are your thoughts on that? Because we did opt to have low dose as our comparator so that we basically could tell everybody you'll be receiving psilocybin, but we didn't do a mg kj. We did straight up 25.
I think again at the time, the thought was this was the best approach to dosing. It's what had been done previously. It's what Roland Griffiths had done in his landmark behavioral pharmacology studies. And only recently did, I believe, Al Garcia Rameau and others at Hopkins conducted analysis that suggests that you don't get a great deal from weight-based dosing. It may not be worth the sort of logistical trouble. But I do think his analysis would suggest you might get a slightly better response with weight-based dosing. His argument was, when you consider all the hassle that's involved in that approach,
right,
and sort of the commercial advantages to a flat-based dose, it's likely not worth it.
Gotcha. Yeah, I mean, that's the, of course, advantage or disadvantage of coming into the field after you guys did all the hard work. So
well, we always knew that would happen, and it was always something we wanted, by the way, was for the big timers to come in and really move this forward. So it's really exciting that that's happening. But by the way, I did pull in table 2. So 65% of the psilocybin participants reported smoking. 70% of those who received placebo reported smoking.
Okay.
So pretty evenly split there.
Yeah.
Hey, Peter.
Yeah.
You were discussing a little bit the manualized CPT and gave some examples, but I was just curious, was that sort of dialogue happening more like in the preparation sessions? Did it shift like over the course of the trial through dosing and then integration?
Yeah. Okay, so this is a good point. So essentially half of the psychotherapy sessions were manualized. So there was a CBT manual and everyone would have received the same content. But the other half was client-centered and non-specific. And I maybe I'm not answering your question, but I think the question really to me is the degree to which the content of psychotherapy changes as a function of the drug that you receive. And something that I would argue, though I don't have any data yet to support this, is that obviously the content or the nature of psychotherapy differs. If you've had a, um, a rather profound subjective experience characterized by a subjective sense of insight and reorientation, then the topic of psychotherapy or the content of psychotherapy is going to be different than if you had a nice nap with diphenhydramine. Um, and you know, if one thing I probably would have done in retrospect, but it just would have been overwhelming considering everything that we were doing that was novel, would have been to code the sessions and sort of characterize how the content of psychotherapy differs. But I just think this is something that's probably unavoidable unless we take that sort of industry approach where we describe what we're doing as psychological support and we pare it down to almost nothing. We didn't do that. We didn't do that in part because I'm a clinical psychologist and this is what I do. But I would say, yes, the nature of psychotherapy changed depending on the drug that was administered. Does that
Got
answer
it.
your question?
Yeah. You said like 5 sessions were manualized. Were those all like on the front end or were
Oh,
they?
we evenly split between
Yeah.
the front and back end.
Okay, cool.
I mean, we there are a couple of things here. Like we wanted to give people the skills needed to go 7 days without using. So that was a requirement. So we wanted to make sure that we were providing these basic skills that would allow them to meet that requirement. We wanted to see ultimately what the added benefit of psilocybin might be after a month of psychotherapy. And I would sort of argue, when you publish in these top medical journals, they give you 3,000 words, so you really bare bones. But I would argue that a lot of the what we might call placebo effect was accounted for by that first month of psychotherapy. What do I mean by that? So um, some of these non-specific factors. So the fact that people are motivated, that they're engaged, that they're optimistic, that they could change, that they're receiving some attention, that they're in the presence of empathic psychotherapists. You're going to see some change, obviously, as a result of a number of these factors, some of which, again, are not necessarily specific to the psychotherapy. But everything was held constant. So there were both specific and non-specific factors that would allow us to track change over that first month. And then from my view, then the question is, what does the drug do above and beyond those psychotherapeutic factors?
I mean, I think that's heroic because I think actually, engaging participants and having them complete count them 5 sessions before they get to dosing is admirable. It's you've got some really special juice. That's good.
Yeah, and if you look at the concert flow chart, plenty of people dropped out.
Yep.
Not everybody received 5 sessions. It was really just those who struggled a bit to adhere to the treatment protocol.
Gotcha.
So let's see. So let me show you the results here. So here is what I really thought of as we had 3 primary outcomes. This is the one that was of most interest to me, just because I think, like many psychologists, I tend not to see outcomes as dichotomous. I wouldn't characterize someone as either having cocaine use disorder or not, even though that's the way the DSM-5 conceptualizes things, and that's sort of a medical model, and there's some value to that. But this is what I felt was interesting and important. So at baseline, in the past 90 days, I'll use my cursor over here. At baseline in the past 90 days, you can see that participants reported being abstinent about half the time on average. So in other words, they're using about every other day. And often the only limiting factor was whether they had the resources to obtain the drug. We had a pre-screening phase where our participants would have been presenting for 2 appointments, in part just to show that they were able to present for 2 appointments. And we're also obtaining some basic demographic measures and blood pressure to assure that they would, in fact, qualify for participation. And as is very common in clinical trials of substance use disorder, people begin to change before you provide them any treatment. And this is one of these non-specific factors, Parker, that I mentioned. Like, people are excited, they're motivated, they've finally decided to do something, they've entered a trial, so they start reducing their use or increasing their abstinence as a consequence of these sort of factors. And then over the course of the cognitive behavioral and client-oriented preparation period, we see a further increase in their abstinence. And so before drug administration, they're very similar. The groups do not differ. There was an effective time, but no effective group. So the two groups increase similarly with regard to abstinence, increasing. And then after drug administration, you see that there is a rather stark break between the two groups, with effect sizes that were almost comically large, from Hedges G of 1.4 to 1.9. I don't really follow social media much, but I think I'd seen someone post about the study and said that even the statistics were hallucinating, which I thought was really funny. And I'll show you that in the next slide, where they were talking about this hallucination. So when it came to complete cocaine abstinence, you'll see that 6 of the 20 participants who received psilocybin reported complete abstinence, nobody in the placebo condition, which yielded a large odds ratio with a very large confidence interval, which I promise is accurate. And that's where there were comments of hallucinating statistics. And I don't know what to tell you other than this is what the data are. And we should, obviously approach this with caution and take it with a grain of salt. Not really sure what to make of this, other than perhaps psilocybin is more likely to elicit complete abstinence. Also, with regard to time to first lapse after drug administration, you see a nice big difference between these conditions. The hazard ratio was 0.28. And, just for example, at day 50 after drug administration, there's a 75% likelihood that those who receive psilocybin are still abstinent versus whatever this might be, 20% or so. So some pretty big differences between those conditions. And obviously, everybody in the or placebo condition eventually did lapse, whereas there were 6 people who didn't in the psilocybin condition. Move on, because I've been talking a lot. I did want to mention some results around some psychological outcomes that are especially relevant to criminal justice involvement. And I was especially interested in pro-social or the flip side, antisocial behavior, empathy deficits. Cocaine use is associated with some deficits in empathy and social cognition. I think in part because when someone is really in the throes of addiction, I'm sure you all know, relationships can become very transactional every day, because it becomes about how am I going to get the drug? And, even as many of you probably know, like sex is currency, so one can trade sex for drugs. So a very intimate act can just be a form of currency. And so the question is, could there be an impact of psilocybin on some of these pro-social outcomes or antisocial outcomes that might be especially relevant to cocaine use disorder? Now, these are preliminary, so we don't yet know if these effects are unique to psilocybin or a function of reductions in cocaine use. We'll see in further analyses, but I did want to show you these for now. So here are changes in Machiavellianism. So this is a personality trait that's characterized by manipulation, cynicism, a sense that everybody's a pawn on my chessboard. And we've probably encountered people like this in our careers, sadly. Like, they're probably very highly successful people who are elevated in Machiavellianism because everyone is just a means to an end. And we did see a rather large group difference at this last follow-up. And why is this a consequence of psilocybin or a consequence of reduced cocaine use? I don't know, but this at least is suggestive of future work that might focus on pro-social behavior that could arise as a consequence, maybe direct consequence of psilocybin, or at least indirect of reduced cocaine use. The next slide is especially interesting to me because this is meaning in life as measured by the Meaning in Life questionnaire. And in many interventions with criminal justice populations, there's an attempt to address meaning, to boost meaning, in large part because, as you might guess, when people feel like they've identified meaning or have meaning in their life, their behavior tends to be consistent with that source of meaning, which for almost all people is usually something that is larger than self and pro-social in orientation. So you generally want people to have their behavior aligned with meaning, because meaning for most of us is about being a good husband or father or brother or daughter or citizen of humanity, whatever it might be. And the largest difference between the two conditions is really at the beginning of integration. So essentially within 2 days after drug administration, we saw a big difference between the conditions, though they really differed from one another through the final follow-up. So one idea might be that a potential mechanism, not the mechanism, but a mechanism would be an enhanced meaning in life. That this could have implications not just for reductions in cocaine use, but also perhaps changes in pro or antisocial behavior. I will say too that this is consistent with my own observations, clinical observations, which are informed by motivational interviewing. I don't know if we can do a quick show of hands. I guess I can only see the conference room, but I wonder how many people might practice MI. Okay, Anna does.
We know about it. Yeah.
Yeah, you know about it at least. So I was a postdoc at UCSF, and one of my colleagues there was, I think, if not his last student, one of Bill Miller's final students. And we had many conversations about motivational interviewing, and it's something that I would do clinically. And I think ultimately, motivational interviewing is an approach that allows people to see how their behavior conflicts with their deeply held personal beliefs. That they're not concordant, they don't comport, and ultimately one wants to align their behavior with what they hold to be most meaningful. I clinically, based only on these observations, so it's anecdotal, have this sense that in a very short period of time, people can, not always, but can have experiences that highlight to them the degree to which their behavior conflicts with their deeply held personal beliefs, and they can emerge motivated to stop their use of cocaine, because in essence, it doesn't at all allow them to be the best version of who they are. And who they see themselves is not somebody who uses cocaine. In fact, the two things are just fundamentally incompatible.
In your manual, Peter, do you talk with people about values and alignment and stuff like that? Because I think our very wonderful PAT team spent some time doing that, so that we sort of probe values, alignments, and even though we're not doing motivational interviewing per se, it's very much in that domain of trying to help people sort of get a perspective on what's important to them and to see how that might need to change.
Yeah, so it wasn't in the manual. The manual is sort of a classic bread and butter CBT.
Gotcha.
But in the client-oriented approach, I think we would, as like a pretty standard Rogerian approach, want to understand, like, where do people find meaning in life? Like, what brings you here, and how do you see your purpose? So these would have been discussed, but not in any systematic way. It could very well make sense to make meaning in life like a systematic and manualized, explicit part of the intervention. And I think one of my colleagues has proposed this at I think I can't remember. I think it might be Gabby Asian Libis. I don't know how to pronounce her name. If she's here, I'm sorry. I always mangle her name, but I think she's interested in this as something that could be targeted specifically. So
one question here.
Yes.
Oh, sorry. Couple questions. So they can find more meaning after a session. They can see that these behaviors are perhaps interfering with being able to achieve meaning. But what about the empowerment to actually make those changes? So there's like two like there's mental block where they feel like maybe they don't have a choice, and then there's the resource block. They might not have the resources to attain those goals that they want to achieve. So did you see anything like that where you were measuring, like they felt more empowered, or they were able to go get that job to make more money, to get the things that they needed? That sort of stuff. Does that make sense?
Yeah, it does. Well, I think for most people we know from this measure, it was simply a matter of whether they perceived there to be the presence of meaning. So there was a change in the degree to which people claimed that they felt they had meaning perhaps was clarified, but they would have said there is more likely to say, yes, there's meaning in my life than before drug administration. To your other question, so these were people who were limited in terms of the resources that they had available to them. So now you're asking me to speculate, which I can do, and I think that's fun to do.
Yeah.
Obviously, these are empirical questions, but if I just left it at that, then this wouldn't be that interesting. So, my sense is that for many people, there were many felt their meaning, where they derived their meaning, was in their relationships with others. So there's often this sense that if there's distance between me and the people I love, I need to reconnect. If I have alienated the people I love because of my cocaine use, and that might be one of their insights. Like my children, I hardly talk to them. My parents, my siblings, I've hardly talked to them because I've been so focused on obtaining cocaine. And now I need to reach out and make amends, by the way, which is sort of consistent with Bill Wilson's idea in AA. Then there wouldn't have been unique resources needed to simply reach out to those family members and begin to mend those connections, which I think is a good thing, right? That for many people, what was most meaningful was just connection to the people they love. I do think, I don't know if there's an imaging component in your trial, but I think Christopher may have mentioned that at some point to me, Chris Nichols.
Yeah, there is.
I do think this is sort of consistent with what Robin Carhart Harris would call like the canalization that is sort of characteristic of many mental health conditions. So people have this sort of laser focus on obtaining, finding, using cocaine, and the impact of their cocaine use on others is often just outside of their conscious awareness. During the acute effects of psilocybin, we see these alterations in brain function, and I think quite literally, like the field of consciousness is expanded. So I actually think psychedelic is a pretty good term for the drug, and people are able to make these connections where they hadn't before, just because they were so laser focused on obtaining and using the drug, and now they realize, oh my gosh, my pursuit of cocaine has harmed the people I really love. I haven't talked to my daughter. I haven't talked to my children. I haven't talked to my parents or siblings. And I realized now I've really hurt them. That feels awful. I need to do something about that. I need to make sure that my behavior aligns with my core values, which for most people would be someone who is a present and supportive, like family member or friend or citizen of humanity. Yeah. I'm just speculating.
Yeah, that's cool. Thanks.
Well, here's some summary. I won't repeat myself. One thing I'll mention is we had no serious treatment-related adverse events. The AEs that we observed were expected, occurred during the session. They resolved, no sequelae. We did not administer any rescue medications. We even had one that the adolescent in me thought was humorous. It was a spontaneous orgasm, which I wouldn't have thought to sort of record as an AE, because it seems like it's something that most people would want, but it is consistent with, maybe not a spontaneous one, but it is consistent with this idea of there being abuse liability. If that were a very common outcome, I would imagine that FDA would be concerned. So we had some interesting outcomes, and we might have been among the first to report that specific adverse event, but nothing serious. So let me switch now, if I could, into some epidemiological work that I've done. Now, most of this I've done with my colleague Otto Simonson, who lives in Sweden, in Stockholm, but the data we collected have been almost exclusively in the US. So sometimes people think it's Swedish epidemiological data. It's US data conducted, but where the analyses are conducted in Stockholm. So the Swedes are sort of watching us and
That's my fault. I think I mentioned in my little blurb about you that you're Swedish epidemiology studies, so they would think that. Yes, I misspoke.
Yeah, well, so one thing we have learned is that it wouldn't really work too well in Sweden, because they're very good at following rules in Sweden, and there's just not a great deal of naturalistic psychedelic use. I've been to Stockholm many times. It's a beautiful place, and the people are wonderful. But they generally have internalized, drug war narratives. That's not necessarily a bad thing. There's just not a whole lot of psychedelic use in Sweden, nor is there really in the UK. I think the US is sort of leading the way. So, we win again, I guess. so I think this is a really important thing to mention is that the vast majority of psychedelic use is occurring outside of clinical trials. So the current estimates are that 12 million US adults have used a psychedelic in the past year, just in the past year. And we all know that like state by state, there are these initiatives that are opening access and decriminalizing psychedelics. There has been a rather surprising increase in past year use in recent years. And use among young adults is at a historic high. So, I mean, consider this, the very largest clinical trials might enroll 400 participants, whereas in the past year, there have been 12 million Americans who have used outside of these very tightly controlled contexts. So I think the question to me is, it's really a tale of two cities, or that may not be the right phrase, but we're really talking about two different things. And what I would say is it might be like this, if you don't mind me sounding somewhat alarmist. In one circumstance, you can go to your dentist office and have your cavity filled by a dentist who's trained to fill cavities. And in the other circumstance, you can come to my basement and have me fill your cavity. And in one context, it could be routine and effective with no issues whatsoever. And in the other, it could be deadly. And the earliest psychologists like Timothy Leary and others noted like one's mindset, one's thoughts and emotions and mood are an important part of the subjective experience, but so is setting. And there's a reason that we've sort of gone out of our way now to make for very comfortable and safe environments. And that's because in the early phases of research, so in that first wave, the data aren't really presented in a way that are systematic and really give us a sense of what the scientists, what kind of data they were collecting, but it was clear they figured out on their own, hey, it's really ideal to have calm, comforting environments where people feel supported. So what happens when people use outside of those settings? So some of the work that my colleagues and I did in the OG days, so like a decade ago or so now, really surprised us. We looked at National Survey of Drug Use and Health data, and we found that lifetime use, even controlling for a range of potential confounding variables, doing our best with the data that are available in the National Survey of Drug Use and Health, are associated with a decreased likelihood of psychological distress, suicidal thinking, planning, attempt, and as well as a range of criminal behaviors like larceny, theft, and violent crime, arrest. Some other folks have found also that lifetime use was linked to a lower odds of opioid dependence and abuse. This is Pisano et al. Now, this really came as a surprise, in part because my assumption was when you're using outside of very carefully controlled settings without a psychotherapist, there's no telling what kind of experience you would have and whether or not there'd be any therapeutic benefit to this. And we still don't know. This is cross-sectional and correlational, but we did try to control for all potential confounding factors. So I think there's at least it's plausible that use even in those contexts could be therapeutic for some people. So even when like Parker goes to all the fish shows this summer, the people using large doses of LSD in the crowd, like I guarantee some of those people are benefiting from it. Some people may in fact though be harmed, and we'll talk about that. We also have done some work. This is one of Otto's ideas. So this is from the folks at Karolinska, and also with the National Survey of Drug Use and Health. Very large sample, by the way, 376,000 respondents. We found a reduced likelihood of heart disease and diabetes among those who've ever used psychedelics. Now, we tried to control for what we could. We threw in all the covariates we could, but we had to make use of what the NSDUH had available to us. And it's still possible that those who use psychedelics are more health conscious or more likely to exercise or have vegan or vegetarian diets or something like that. It seems consistent with my experience, like at the psychedelic science gatherings. They seem to be like a generally healthier group of people. But nevertheless, there's some signal here that suggests perhaps there's a direct effect of psychedelics, say on chronic inflammation, or that there are implications for enhanced health behavior. But let's get to the risks that I think are worth noting. So this was a cross-sectional study and of a relatively small sample, but now we're designing our own surveys and we're trying to ensure we have people who are not self-selected. So we use prolific academic, and we try to recruit samples that are representative of the populations that we're interested in here. And though most people, so 60% or so, report no challenge, no distress, the remainder do report some challenge associated with their psychedelic experiences, with some reporting an impairment of a day or more. And in some cases, there are thoughts of self-harm or even self-harm attempts. Some people who report severe impairment, and some people who seek help. And if you followed the journalist Jules Evans and his reporting on this, I think this is really important. Nothing we do is without risk, obviously. And the media coverage of psychedelics, I do think, has been uncritically positive, which is a little concerning from a public health perspective. Though most people can use a psychedelic and be perfectly fine, in fact, might benefit, there are some who I think are at particular risk. So the big question is, who is at particular risk? We know in part predictors of challenge would be those who say the dose was too large, or they had no support, or they were experiencing a major life stressor right beforehand. So that begins to tell some of the story, but there's more. We're interested in, I always get this off a little bit, hallucinogen persisting perceptual disorder, which is not well understood and probably quite rare. But it is something that happens, and I would imagine it's something that mostly relates to like visual centers in the brain. But we were interested in those who reported an HPPD diagnosis and those who were essentially reporting unusual visual experiences on a questionnaire that is often used to screen for the presence of psychotic symptoms. Now, if you look at those who have a family history of a psychotic or bipolar disorder and compare them to those with no family history, at least in this survey, which is larger than our prior surveys, the psychotic symptom severity was essentially the same depending on that family history, which is nice to see, and it might be that if you're familiar with like diathesis stress models, that for the most part, the sort of stress across these conditions may have been low, such that neither one of them were at especially high risk of psychotic symptoms. But if they did report psychedelic use, then sure enough, those with a family history of psychotic or bipolar disorder reported greater psychotic symptoms than among those who did not have such a family history. And an HPPD diagnosis was rare, but more common among those who had used psychedelics in the past. So there's something here perhaps around genetic vulnerability, and in most of our clinical trials, as I'm sure as is the case of yours, we would exclude those who have a family history of bipolar disorder, psychosis, or psychotic disorders. That might be one condition or one patient population that may not be a good candidate moving forward, but we need to understand this a bit better. This is also really an interesting study that we published very recently. And in this study, we actually found an association of increased depression with naturalistic psychedelic use. These are shifting targets, and this finding is sort of a consequence of the sample we recruited at the time that we recruited this sample. But in essence, we found, consistent with mediation, I don't think that we did a formal mediation analysis, but at least consistent with mediation, we found that those who used in what we would have characterized as a risk context based on our prior work had more challenging experiences, which was in turn associated with greater depressive symptoms. Those who used outside of such context did not report a worsening of depression symptoms. So this overall increase in depression associated with naturalistic use was accounted for by people who are using in risky contexts and having very challenging experiences as a result. And I think this really does tell a story around context mattering, and there could be some indication here that with the, I think, again, rather uncritically positive coverage of psychedelics, that people, perhaps especially young people, are using in contexts that are far less than ideal, which could lead to worsening in mood. Let's see. Here is a longitudinal study that we published recently. And we found that the severity of psychotic symptoms rose after use, but only when use was in an illegal or unsupervised context. So again, we're trying to get at these riskier contexts. And we found the same pattern with mania. The symptoms only seemed to get worse when people were using in contexts that were far less than ideal. When perhaps they were concerned about the legality of their actions, concerned about getting arrested during use, or were there without anybody to really help them through the experience. Let's see. There's also an association of adverse childhood experiences here. And essentially, those who have more difficult experiences are those who've had a history of adverse experiences in childhood. As you can see, there's a clear dose-response relationship here. And the most common sort of challenging experiences that people reported were anxiety, negative self-concept, and social disconnection. These are very recent findings from sort of shared trainee Michelle Olofsson, who's both a Swedish and American citizen living in Bethesda right now. So this again begins to tell a story around who might be vulnerable to difficult experiences, which to date appear to confer some not just risk, but like risk of adverse outcomes, of not therapeutic outcomes, but harm.
And do you think that these are these also in like outside of clinical setting?
Yeah, this is all naturalistic use.
Because
none of this is clinical trial data.
Because we'd also, think that something like psilocybin or MDMA would be useful for individuals who have experienced trauma.
Yeah.
So it's a little counterintuitive to see that risk, but maybe it's just in the wrong context.
I think that might be it. I think that might very well be. Now, we did only really capture the degree to which they were having challenging experiences. So we know that challenging experiences are generally associated with therapeutic effects that are not as prominent or maybe even harmful outcomes. But in this case, we didn't make that connection explicitly. So all we know is that they had a more subjectively challenging experience. And it could be that these challenging experiences are beneficial. If you talk to a psychotherapist, of course, they're going to say it kind of depends on how that's handled after.
Yeah, good point.
So this is, I think, the take home from these slides. I think the very same molecule can be very helpful or harmful depending on the context. And what tips the balance here? Supportive setting consistent with the clinical observations of the older researchers, screening participants and excluding from participation, at least those for now with the family history of bipolar disorders or psychotic disorder, and administering a dose that is appropriate. Preparation and integration, I think, are an important part of this process. Some form of psychotherapy, we can label it psychological support if we want to, but I think some sort of interpersonal support makes sense. And at least for now, it appears that those with low adverse childhood burden are more likely to benefit. But I'm not at the point where I'd say we should exclude these people from participation. I think we just need to be aware clinically of who might be more likely to struggle and be prepared to support them. Of course, those variables that tip toward harm would be a sort of negative mindset, no support, a large or unexpected dose, an illegal or unsupervised use, family history of psychosis or bipolar disorder, the adverse childhood burden, as I mentioned, and major life stressor beforehand. This is important because there's some data to suggest there are a fair number of people, especially young people, who use often in a situation like this. Like Peter approaches Christopher and is like, "Hey, man, I got a whole bunch of mushrooms. You want to try it?" And Christopher just says, "Okay," and he eats them. This is sort of the nature of people who use substances. They tend to be a little disinhibited. So there's a lot of this sort of use that occurs without any planning, without any reference to the literature, without having any idea what you're getting into, other than I'm ingesting a drug. And it's likely those sort of circumstances that I think are likely to produce harm or challenge. I also think for any epidemiologist here, we have some important research priorities for the future, because Compass, Usona, these psilocybin formulations will likely be approved before the end of the year. and use will occur in very carefully controlled clinical contexts. But I think the majority of use will always be accounted for by use outside of these contexts, because one can grow their own or go foraging. And that's what's really unique about psychedelics, as we're moving through the FDA process, drugs that are otherwise fairly easily accessible outside of these settings. So I think we need to better understand the full range of adverse effects. There could be many that are not well characterized, in part because the clinical trial data have involved small samples of carefully selected people. I really want to understand, using epidemiological approaches, for whom and under what circumstances there is risk. And this could inform public health campaigns and education. I tend to be fairly libertarian in a sense around drug use. Like, I feel people should be free to do what they choose. In fact, they are, but I would like them to be informed, and I would like to do what I can to collect data that can inform these education campaigns. There need to be treatments for persistent harms. There are really few options at all for conditions like HPPD, for example, that follow naturalistic use. And we need to understand how to best help people who've had experiences kind of rock them. And as a clinician here at UAB, fairly frequently I am contacted by people from the community who've had experiences with a psychedelic or even like 5-MeO-DMT and just kind of feel rocked. I think the term ontological shock has been used. So, what do we do when people present to us having sort of had, in some ways, this sense that like their understanding of reality is kind of crumpled before them and they don't know what to do moving forward? I think we need to better understand how to treat these folks. And as always, we're scientists, so we're going to say there needs to be more funding around this, but there does. We need funding for understanding these adverse effects and for engaging in harm reduction, which we hope would be in proportion to the hype. And there's plenty of hype right now, unfortunately, a little too much. Okay, with that slide, I will open the floor now to questions. And again, thank you very much for having me.
I think that's great. And you have a question on your chat?
Oh, I do? Okay, let me see. Let me stop sharing so I can access it. Stop share. Okay. Oh, got some questions there. Okay. What about the strong social connections maintained through substance use and folks who identify strongly with substance using communities, e.g. identifying as an addict and feeling like the only social connections they have are through drug use or chemsex communities? Wow, that's a great question.
I asked that question. I can add some context if needed. And I have another question about your study. But thank you so much for this talk. It's so important, and I'm really grateful to be joining all of you from sunny San Diego, California. I'm also a substance use researcher in this space and a clinical psychologist in training. And that question is mostly related to the harm reduction research I do, and a lot of people identifying very strongly with their substance use communities, especially if they have many other kind of contextual factors that are limiting their social, I want to say structural factors that are limiting their social connections, and finding a lot of community in their space, and that being inhibitory to them wanting to achieve abstinence or harm reduction or like reduced use. So what about those folks who, when you talked about values alignment, people like getting more in touch with, oh yeah, it's really values aligned for me to be there for my kids and my family. What about the flip end of people who are finding a lot of social connection within their use communities?
Well, the study that we conducted obviously was a small one. There was an N of 40. I can't say that came up for those 40 people. And I think by the time that they found their way to us, they were pretty motivated to stop. There probably wasn't a great deal of ambivalence, but some. But we didn't encounter anybody who would have said to us, but everybody I know and all my friends and all my connections are people who use cocaine. I think more commonly they would have said, I'm in a bad place, and I need to not be in a place where everybody I know uses cocaine. But it would be really interesting to see what would happen with people like that. I guess one question is, are these people who also show for highly demanding clinical trials? I'm sure. But
Right.
it would be really interesting to see what kind of experiences they have. My first guess is that they'd probably say, all right, like, I'm having a bit of a crisis here, but I need to really find a new community. Or not.
That makes a lot of sense.
Maybe this is a big obstacle to quitting, if they feel like, yeah, I get it, but also this is how I connect with others. I know that I don't really want to give anything away, but for some of my colleagues who worked with methamphetamine,
Mhm.
and this was to some degree the case with cocaine. There was in my study people who would have said, I have now found that without cocaine or methamphetamine, that like sexual interactions are much less rewarding. That this enhanced sex for me so much, and that's how I connected with other people. How do I do that now?
That makes a lot of sense. My other question, and this is not, again, really brilliant talk, and I appreciate it a lot. So it's not meant as a criticism. It's merely a curiosity. Since we know that like single substance use is kind of a myth and research is limited in that way because our clinical trials always have to like focus on one primary thing. Most people, and in your naturalistic studies, you know this as well, that people are using multiple substances. Even in the psychedelic space, polysubstance use is like the norm, not the exception. And so when you're controlling for people's cocaine use and looking at reductions, did you notice or record any compensatory use or switching to other substances? Did you control for any other, when people are abstinent in your clinical trial, are they only abstinent from cocaine and maybe not others? How did you navigate, people mostly using more than one drug, and did that affect outcomes at all?
Great question. And I'll say, and I'm sure Anna Rose could say this, and anybody else who submits papers and grants, like all we are ever doing is getting criticized. So
not meant as a criticism, it's a curiosity.
But like there's no way that you could hurt my feelings at this point. Like I live in a world of rejection. But so to that question, we required a DSM-4 diagnosis of cocaine dependence. We allowed abuse but not dependence on other drugs, with the exception of tobacco, where people could have smoked every day and they would have participated. So I'm looking over some of the data we have here. So 18 of the 40 people were smokers. There were 24 of the 40 who reported any heavy drinking in the past 90 days. So there was some heavy drinking, and alcohol consumption and cocaine use are very frequently comorbid, in part because the alcohol use can sort of prolong the effects of cocaine, can also make cocaine use especially toxic. So we do have data on alcohol consumption, and there was a fair amount of alcohol consumption. There's a fair amount of cannabis use. Really about 50% of the sample reported some degree of cannabis use, though there was very little use of methamphetamine or other stimulants, depressants, very little use of opioids, heroin. And I should also say, of the 40 people, only 3 had ever used a hallucinogen in the past. And in most cases, of those 3, 2 were men like in their 50s who kind of remembered having used maybe LSD when they were a teenager. So we allowed for some use, but cocaine would have been the drug of choice and would have been the drug that was really causing the most problems. We are going to report on changes in alcohol use among those who were drinking. And there was no evidence of any kind of compensatory use. We actually reported that in the paper because one of the reviewers wanted us to mention that. So there's just no evidence that anybody started using more of one substance or the other. Although one thing I think we could find, which I think is really interesting, is some participants seem to, after their participation ended, reach out and find like NA or AA communities and started smoking because everybody at those meetings smokes and drinks coffee. So
I think social component again.
Yeah, I think we might find that it's possible that there was a change where some people started smoking more, which would be really bad because smoking is still the number one cause of premature death and illness in the United States. So that could be one finding that we report, that you get psilocybin, you stop using cocaine, you start smoking. That would be worth reporting, but I haven't really looked at the data just yet. A lot of people are smoking blunts also, where they might think of that as just cannabis use, but they're also using tobacco, even if they don't think of it as tobacco. So there'll be some interesting analyses that we do there, but I can at least say there was no evidence of compensation or substitution.
It's pretty amazing. Thank you so much.
Thank you.
May I ask a question? A very interesting discussion, but I want to ask, was it a single dose of psilocybin?
One dose.
Yeah, because I think the big difference between the second half of your talk and the first half is the number of dosing, because I think there's a diminishing return with this category of drugs, because it really resets several of the neural pathways at once. So to do it in a repetitive fashion, you could see where that would become harmful before too long. I mean, just think about your computer resetting it. So,
Yeah.
but on the other hand, resetting your brain after a certain, let's say, after 20 years may be really a good idea, or maybe every 20 years, but not doing it in a repetitive fashion for social or entertainment value, but for some therapeutic value.
Yeah, I completely agree with you. And let me say a couple things about that. So I don't think there's any human or animal model yet that's shown kind of compulsive drug seeking. So I don't think you'd ever find a human being who'd tell you, I really wish I could stop using psilocybin, but I can't, I've lost control. Don't think you'd find that. But I definitely do think you'd find people who are using in manners that we would probably identify as problematic, as harmful and not helping them. But there are a lot of things that people do that kind of fit that description. Even exercise. People exercise too much.
Right.
People can do too much mindfulness meditation. They can go to yoga too frequently. They can engage in, I think, too frequent religious observation. We wouldn't call it addictive, but we would say there's a pattern here that's not helpful. And consistent with this, there's this. So I think spiritual bypassing is a fascinating concept. And this comes from like the world of the psychology of religion or spirituality. And the idea could be that one would have a kind of profound spiritual experience that is characterized by these insights. And instead of saying, okay, I'm going to take that information and apply it and do something with it, you say, ooh, I want to have that experience again and again and again and again. And I think we do see that sometimes in the world of psychedelics. What is it? Alan Watts, someone correct me, had this sort of famous funny line where he'd say, well, when you get the message, you hang up the phone. So if there is this sort of analog with like an Ebenezer Scrooge like experience, which speaking of Bill Miller, he talked about quantum change and referenced his own interest in Ebenezer Scrooge or the story of Ebenezer Scrooge as a motivation for him understanding this sort of phenomenon better. That people are going to have like these really meaningful experiences that lead to sudden, dramatic, and durable change. If we think of that Ebenezer Scrooge like experience as maybe in part what's happening here, then obviously Ebenezer would not say, I need to be visited every Christmas Eve to stop being a stingy, greedy, mean old codger. But maybe with mood disorders and other things that are maybe a little less volitional, we might have a place for some kind of repeat administration. But I think the comment is absolutely correct. If you're doing this every weekend, it's probably not a good thing.
Other questions in the chat or I think there's something else.
Parker.
Yeah, I had just one more question. Peter, this is like a really understudied group, as you mentioned, and I was just curious if for the cocaine use disorder study, did in like the acute subjective experience data, did anything come out of that looked, I don't know, different in any way from like what we've seen in all the weird
No,
clinical trials?
I don't think so. I think mystical experience as measured by the MEQ, as measured by the APZ, which is sort of a precursor to the 5D ASC, and as measured by the Hood mysticism scale, was much greater among those who received psilocybin. But I'll tell you this, there are always exceptions to this. I had one participant who I now know, I wouldn't have known at the time, but I now know received a very large dose, like 50 milligrams, because he was a bigger person. And afterwards, he just kind of shrugged his shoulders and said, thank you for setting up this day for me. And the music was beautiful. And I can see you took some time to decorate the room. And I felt very comfortable and supported. But, I got the placebo. I don't have much to say. I got the placebo, but the music was nice. Thank you, though. I appreciate it. He returned the next day, sort of smiling ear to ear, and said, well, I got the placebo because I have nothing to tell you about my experience. But in the meantime, God performed a miracle and just took my urge away. It's gone. He was one of the 6 people who reported complete abstinence. And, keep in mind, I was the primary investigator, but also the lead therapist here. So, imperfect. But I guessed he received the placebo. He was, of the 40 people, the only person I guessed wrong. And
he thought he received a placebo, and yet he was one of the 6 people who reported complete abstinence.
That's intriguing.
And if you look at the older literature, I think there's some indication that the scientists then would have said, we don't really know how to predict the sort of experience that people will have. Like the confidence intervals are just really wide. Like sometimes they have these beautiful mystical experiences, and sometimes they don't. Sometimes they just shrug their shoulders. So I don't know what to tell you with that, but in general, yes, there was more mystical experience among those who got the active drug, but there are exceptions to that.